Okay, so the case we'll be talking about today, this was a 73-year-old male. He had some comorbidities at presentation with coronary artery disease, also atrial fibrillation, diabetes, and high cholesterol as well. He presented initially due to a progressive leukocytosis noted on his labs done by his PCP. At the time of presentation, he noted perhaps some mild fatigue as well, but no constitutional symptoms or any other real noticeable symptoms at all. At presentation, his rising white count was found to be 22.7 with an ANC of 7, an absolute monocyte count of 5,400, basophils at 540. He also had a hemoglobin of 16.1, which had been gradually rising at the time, and he was normocytic with an MCV of 93. He had a hematocrit of 50, which was mildly elevated, and his platelets had intermittent low reads and low normal reads due to clumping. Bone marrow biopsy was performed, and he was found to have 95% cellularity. He was found to have 30 to 40% B lymphoblasts, which is consistent with a B lymphoblastic phase of CML. He was also positive for the P190 breakpoint transcript of BCR-ABL in 30 to 40% of these blasts, and the NGS results from this marrow are to follow. He was positive for an ASXL1 and IKZF1 mutation as well. His karyotype showed the 922 translocation and also a monosomy 7 with a chromosome 8, gain of chromosome 8. And he was started on first-line treatment with mini CVD, alternating with blinatumomab and with ponatinib as well. He gradually was able to obtain a morphologic complete remission and was negative by flow cytometry for MRD testing, but was not able to achieve complete eradication of his BCR-ABL transcript.
So, as I just mentioned, that we see definitely the fusions, the 922 BCR-ABL fusion, but it is a P190 expression. And we see some HPV virals. There are mutations in SXL and NF2 here. So this is actually, as you can really see here, the breakpoint on the ABL at first exons, which is consistent with 190. Now, and this is actually the monosomy 7, and the 8 is this very faint subclone showing very little of the plus 8. Very difficult really to see it, that much. So these are the mutations, as you can really see them here, NF2 at high level and ASXL at high level. And the clonalities, as you can really see it here, there is a clonality, but the expression, again, this is acute lymphoblastic leukemia. The expression is very low, but we see clonality with lambda. We don't see, of course, clonality with kappa, for the heavy chains, and the expression is extremely low, which is typical for acute lymphoblastic leukemia. Now, the cases presented with clinical pictures similar to CML. This is extremely unusual to see CML with BCR-ABL with P190. But there are some cases, and as a matter of fact, on the top is a paper we published in 1999, and in that paper, there are only 5 out of 1,384 cases at MD Anderson at that time we published. All these cases will show a degree of monocytosis. So whenever you have CMML or a picture of CMML with monocytosis, the possibilities of being expressing the B190 is absolutely there. But these cases are extremely rare. And even in this case, as you all know, sometimes cases with acute lymphoblastic leukemia may represent with eosinophilia prior to the overt acute lymphoblastic leukemia and perhaps high white cell counts. Now, recent or subsequent paper from MD Anderson suggested that these patients would not respond as good to TKI, as good as if there is expression of the 290, even when they are in the chronic phase. So the question, in my opinion, remains for this case, whether it is still blast crisis of CML or de novo acute lymphoblastic leukemia with a B190. In a principle, for me, whenever I see B190, I always expect acute lymphoblastic leukemia rather than chronic myeloid leukemia.
And yeah, I just added a visualization here to maybe prompt some discussion. Just kind of a picture of the general knowledge we have of genetic predictors of myeloid and lymphoid blast phase in CML. There's some more general mutations, like an additional ABL1 kinase domain or a RUNX1 mutation. But there are some genetic predispositions to myeloid versus blast phase. Kind of consistent with our patient, more indicative of a lymphoid blast phase might be a monosomy 7 or perhaps an IKZF1 mutation. In myeloid blast phase, which is more common, patients can present with a P53 mutation. ASXL1 typically predates the conversion to blast phase, so a lot of chronic phase CML patients will be already ASXL1 positive, and then we'll gain other somatic mutations as they transform. And then, can I go to the next slide here? Yeah, this is a very busy slide, but just kind of to show the scope of the numerous mutations that can be associated with either sort of blast phase. These are patients that had whole exome sequencing while they were in chronic phase, and then again while they were in blast phase. And as you can see, it just reiterates some of the previous information with various mutations being associated with each.
Right, but these are for CML with the 210, not with the 190.
Yes.
So when it comes to 190, it is most likely a completely different ballgame. But again, there are too few cases in the literature. We see them very rare.